Okay, so we are on page 993 for chapters 22, starting on chapter 22, but this is chapter 22 and 23 unit over cardiothoracic surgery. Now, if you'll look on your schedule, we are doing part 1 and part 3 for the first portion of lecture. So part 1 is over thoracic surgery, part 3 is over pediatric cardiac, and then in the next lecture, we're going to do part 2, which is the adult cardiac section. So you are free to skip around to the slides that are pertaining to parts 1 and 3, or if you want to listen to all of this presentation as a whole, that's fine. But the chapter does start on 993, but we will start this lecture on page 994. Okay, so on 994, you can see there's your key terms, which I will be talking about through this PowerPoint. And then there's the introduction, but so you see in the red, there's that mediastinum, and the mediastinum is the middle area of the thoracic cavity between the lungs. So just make sure that you know that term. All right, so under diagnostic procedures and tests, you pretty much need to know the majority of this area. So diagnostic procedures and tests that are most frequently used in the diagnosis of thoracic diseases and disorders are made up of pulmonary function, laboratory tests, and imaging studies that include standard X-rays, CT scanning, MRI, and pulmonary angiography. Anteroposterior or AP and lateral standard X-rays of the chest can determine the size of the heart and great vessel configuration, as well as any valvular or intracoronary calcification. Asymptomatic pericardial cysts and cardiac tumors may also be detected. CT scan and MRI are used for the evaluation of pericardial and intracardiac masses. CT scan is especially useful for the detection and evaluation of thoracic aorta dissection. MRI can detect abnormal positioning of intracardiac structures. Pulmonary angiography is primarily used to detect pulmonary embolism and other blockages of the arterial circulation in the lungs. It is also used to help diagnose congenital narrowing of the pulmonary vessels, pulmonary artery aneurysms, and an aneurysm is a sac formed by localizing dilatation dilatation of the walls of an artery due to structural weakening. So you have an abnormal, uh, just a weakened artery or vein, usually it's an artery, that wall is weakened, and so if it weakens anymore, it's going to burst. Okay, so aneurysms, and changes to the arteries due to pulmonary hypertension. Okay, and so skip down a little bit in that last little paragraph above that figure 22-1. It says the 3 definitive diagnostic procedures for the diagnosis of suspected lesions are bronchoscopy, mediastinoscopy, and thoracoscopy with the excision of tissue and fluid specimens. Okay, so on the next page you can see all of the instrumentation, the equipment and supplies. There's a vascular instrumentation set on 995, and you can see on 996 what these instruments look like. I want you to focus on letter G. That is the Lovelace lung grasping forceps, and you may want to write next to it that it looks like a large Pennington. So a Pennington is that instrument that has an upside down triangle, Pennington. So G, that Lovelace, looks like a large Pennington. Okay, on 997, on that table 22-2, there's the thoracotomy instrument set. And if you go about halfway down, notice how there are 2 Lovelace or Duval lung grasping forceps. Okay, so there's that, it comes back right there. Okay, so continuing with the equipment on 997, on the left-hand side, 1, 2, 3, 4, 5, the 6th and 7th bullet, so you need some chest tubes of various adult or pediatric sizes, and a closed seal drainage unit like the Pleurovac. And we'll talk more about this. I think there might be some pictures later on, or else we'll look at those in class. Okay, so we're going to be on this slide for a long time. This is a very lengthy chapter. So we're going to start on 998 talking about bronchoscopy, and the previous slide talks about the anesthesia monitoring equipment. You will need to be familiar with those, especially like the swan gans and the ABGs and things like that. You'll hear that a lot in the bypass room. But right now, let's focus on the bronchoscopy. So we're going to do a lot of highlighting here. There's a lot of anatomy. Okay, the thorax. There are three divisions of the thoracic cavity. The right pleural cavity, which contains the right lung, and the right lung has 3 lobes. Then also is the left pleural cavity, and the left lung has 2 lobes. And then in the thorax, there is the mediastinum, and within the mediastinum, it divides down into the esophagus, trachea, thymus, lymph nodes, and then the heart with great vessels. So notice the divisions here. So there's thorax, that divides down into the right and left pleural cavity, and the mediastinum. So those are your 3 divisions, and make sure that you know the lobes and what is what falls under the mediastinum. Okay, third bullet, there's your sternum. That is superior to inferior. And within the sternum, the sternal body, there's the manubrium, the body, and the xiphoid process. You should know the xiphoid process if you've taken CPR, because that's what you find with your finger, and then you go 2 fingers width above that to start compressions. The xiphoid process, the tip of that sternum. And you can see all this on the next page in that 22-4, the upper right hand corner where there's an arrow, there is pointing to that xiphoid process. All right, next is the 12 ribs. So that second little bullet, there's 7 true ribs, and then 3 false ribs, and then 2 false or floating ribs. Okay. All right, so that's the thorax. Now let's back out and let's do pleura. So the parietal pleura, and pleura, let me turn the page here. Pleura is a thin serous membrane that encloses the lung, composed of a single layer of mesothelial cells on top of a thin layer of connective tissue. It is divided into the visceral and parietal pleural layers. Okay. All right, so parietal or parietal, I say parietal, I guess. Pleural lines, lines inner surface of the ribs, pericardium of the heart, and superior surface of the diaphragm. The visceral pleura covers outer surface of the lung. Pleural space is the small space between the parietal pleura and visceral pleura. It contains serous fluid that prevents friction between the lungs and pleura during respiration. So let's talk about respiration. The principal muscles associated with inspiration, and inspiration is the act of drawing air into the lungs to facilitate the exchange of oxygen for carbon dioxide that is then exhaled. So those muscles associated with with inspiration are the diaphragm and external intercostals. So then further down, the principal muscles associated with expiration, and expiration is also called exhalation, that refers to the passive exhaling of air from the lungs. Those muscles are the internal intercostals, external oblique, internal oblique, transverse abdominis, and rectus abdominis. So you can see there are more muscles involved as you blow out than when you inhale in. Okay, the trachea. The trachea extends from larynx to bronchi. The trachea is formed by a smooth muscle, hyaline cartilage, and hyaline cartilage is an elastic connective tissue that covers the ends of bones, supports the trachea and larynx, and connects the ribs to the sternum. It is covered by the perichondrium, not cardium, perichondrium, and calcifies as the individual ages. Okay. So smooth muscle, hyaline cartilage with C-shaped rings prevent trachea from collapsing. The inner wall is lined with ciliated mucosa. Trachea functions as passageway for air to and from the lungs. So then there's the bronchial tree. So the trachea divides, excuse me, at the carina into the right and left bronchi. And so that third bullet, that last little sentence, mucosa is composed of goblet cells. Goblet cell secretions trap foreign particles. Cilia pass the particles forward into the throat to be expelled as an aid in preventing respiratory tract infections. So let's look at the bronchial divisions. So the bronchus enters the lung and divides into secondary lobar branches. The lobar branches divide into segmental bronchi. Segmental bronchi divide into bronchioles. Bronchioles end in alveolar ducts and alveoli. And alveoli are composed of simple squamous epithelium, and they exchange oxygen and carbon dioxide. So you can see a beautiful structure on page 1000 in that 22-6 of the trachea, the lungs, and the other structures that we just talked about. And notice at the top of this whole structure is that hyoid bone. And you can see the hyoid bone again on 1001. Okay. Okay, and then you can also see the muscles of respiration up at upper left on 1000. So let's talk about the lungs. Lungs extend from just slightly below the clavicle to the diaphragm. Ancillary structures, and you need to circle ancillary structures, and right next to it, the ancillary structures, they enter the lung through the hilum. The ancillary structures enter the lung through hilum, H-I-L-U-M. And those ancillary structures are the bronchus, pulmonary artery, superior pulmonary vein, inferior pulmonary vein, lymphatic vessels. And so the hilum is a slight concave portion on medial side of each lung where the bronchus and other structures enter. But it doesn't specifically say ancillary, so if you see on a quiz or a test the ancillary structures enter through where, you're going to put the hilum. And here they are. Bronchus and other structures enter through the hilum. Okay, I'm just spelling it out for you. Okay, blood flow. Blood low in oxygen travels from the right ventricle of the heart through the left branch of the pulmonary artery to the left lung to be oxygenated. And oxygenated is just saturated with oxygen. Blood travels in the same way to the right lung, except it travels through the right branch of the pulmonary artery. Oxygenated blood leaves the lungs through the pulmonary veins and enters the left atrium of the heart. Bronchial arteries that arise from the aorta supply the bronchi, bronchioles, and tissue of the lungs. And so before we get to lung damage, I want you to circle up at the upper left on this diagram where it says larynx. Make sure you know the position of the larynx. It is proximal and superior. And we're talking about to the lungs. The larynx is proximal and superior to the lungs. Okay, I would write that. Okay, lung damage. Bronchoscopy is an invasive diagnostic and/or therapeutic procedure for the evaluation of hemoptysis, and hemoptysis is the sputum that is coughed up that contains blood. All right, so hemoptysis, infection, carcinoma of the lung, and damage to the lungs due to smoke inhalation. It is useful for retrieving foreign objects lodged in the airway and for laser treatment of endobronchial tumors. Bronchoscopy is also useful for postoperative evaluation of the transplanted lung. Carcinoma of the lung is the leading cause of death due to cancer in the United States. In most cases, lung cancer is the result of cigarette smoking. All right, so continuing on to 1002, there's the lung structure again. But that first bullet, lung tumors are divided into 4 subgroups. There's small cell carcinoma, squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Okay. All right. So on 1004, under the pre-op preparation, you are in the supine position with a scapular roll to hyperextend the neck, or the head is slightly lowered by lowering the headpiece of the table. We need that trachea to be as straight as possible, so we need the head tilted back all the way to stick that scope all the way through down into the lungs with no kinks. All right, practical considerations. Bronchoscopes are either rigid or flexible. And this gets a little confusing, so hang with me here. The rigid scope is equipped with a fiber optic light carrier for illumination of the trachea and primary bronchi and side channels for anesthetic gas and oxygen administration. Rigid bronchoscopy is typically performed for the removal of foreign objects in children, although it may occasionally be used for biopsy of a large central mass or for evaluating hemoptysis, which again is that coughing up blood. The smaller diameter flexible fiber optic bronchoscope allows for visualization of the upper, middle, and lower lobe bronchi and may have a video camera attached for viewing on a monitor. Transbronchial lung biopsy for examination of pulmonary infiltrate. And infiltrate is that accumulation or diffusion of a foreign substance into tissue. So that pulmonary infiltrate is also performed through the flexible bronchoscope. Now, you need to write something at the bottom pointing to the word infiltrate. So infiltrate shows, you can see these as the infiltrate as changes in density on chest x-ray. You can see infiltrate by looking at the changes in the density on a chest x-ray. Okay. Because the scope is inserted through the mouth and into the bronchial tubes, the procedure is not treated as a sterile one. And you'll see this. You'll see, like, especially at Mercy, they'll do Super Ds, and that's what they're doing. They're doing lung biopsies. It's clean, pretty much. I mean, everyone's in their sterile attire. The sterile site is there and the sterile back table, but really, it's just a clean case. Okay, on 1005, still under practical considerations, that last bullet in the first column, halfway down it says a brush or biopsy forceps. So that is how we're acquiring these specimens for lung tissue, is using a brush or a biopsy forceps. Typically it's going to be the brush. Last bullet in the second column that continues into the third, cytologic specimens from bronchial washings delivered through the flexible bronchoscope are essential for the diagnosis of lung disease. Bronchial brushings and needle aspirations may also be performed through the flexible bronchoscope, and specimens taken with a flexible biting tip, forceps, may be sent to the laboratory for tissue identification. Okay, so you can see on 1006, that's the position that we're wanting, that diagram or that little illustration. Straight, you want a straight shot into the lungs, so they're going to be hyperextended for a while, that patient is. So that takes us to the mediastinoscopy on 1007. So under pathology, mediastinoscopy is performed for the evaluation of nodal involvement or mediastinal masses in the patients with lung carcinoma. Next bullet, mass lesions tend to be enterogenous cysts, lymphomas, neurogenic tumors, and pleuropericardial cysts. Okay. On the next page on 1008, under the practical considerations, mediastinoscopy is a sterile procedure. Okay, you are going to be making an incision into that mediastinum to go directly down to where they're needing to look at. Okay, so this is different than a bronchoscopy. All right, on 1009, the VATS, the video-assisted thoracic surgery. VATS evolved from thoracoscopy as well as the advances made in minimally invasive surgical techniques and instrumentation. VATS is used for the diagnosis and treatment of several thoracic diseases and disorders of the esophagus, lungs, mediastinum, pericardium, and pleura. All right, on 1010, under the equipment, that fourth bullet, you have a fiber optic light source. And also, second column, halfway down, you have an endoscopic linear stapler. And then you also, in the third column, second from the last, you have a plurivac closed water seal drainage system. Okay, so we are fully into the lungs. We're doing some actual surgery. And you can read all about that. You can see that on 1012 what's going on. So there is an incision. We're in the lateral position. Okay. On 1013, that pearl of wisdom, make sure that you know this. It says, unlike with laparoscopic procedures, the thorax cannot be insufflated for expansion. Therefore, double lumen endotracheal tubes that allow single lung ventilation and collapse of the lung on the affected side are essential. Okay. So we can't blow up the lungs anymore. Okay, so we have to let that patient ventilate with one lung while we work on the collapsed lung. Okay, the Nus pectus excavatum repair by VATS. The most common congenital deformity of the chest is a funnel-shaped asymmetrical depression due to a posterior displacement of the sternal body, referred to as pectus excavatum or funnel chest. The deformity usually affects 4 to 5 ribs on each side of the sternum. In extreme cases, the sternum may be even reach the vertebral column. So basically, these are the people that are laying down and they have a valley in their chest. You can pour water into how sunken down their chest is. It can hold a substantial amount of water. It's that much of a dip. And it can go all the way down to that vertebral body. The cause of the abnormal growth of the costal cartilage and sternum is not known, but its occurrence along with Marfan syndrome and or kyphosis is common. And when Rachel Ray is here, I'm going to have her talk to you about Marfan syndrome, but you can pretty much see these people. These are very, very tall and lanky people with huge hands. But this is a syndrome and you can research that more so on your own. And kyphosis, those are the people that are hunched back. They're your older people. They have kyphotic, just very arthritic vertebral column. But yeah, these are your hunchback people that they just have bone on bone. It's really bad. But you can see what I'm talking about on 1015, that pectus excavatum. You can see in A how there's just this sunken chest look, and it's usually you can notice this at birth. Okay, 1016, pulmonary thromboendarterectomy. Pulmonary embolism obstructs the pulmonary artery, resulting in life-threatening chronic pulmonary hypertension and its associated complications. Next column at the top, the earliest sign is severe pulmonary hypertension when exercising. However, the patient may not consider the symptoms abnormal and not report to the physician. All right, under the pre-op diagnostic test, the second bullet all the way through. Echocardiography, that is used to visualize septal hypertrophy, tricuspid regurgitation, right atrial enlargement. CT angiography, that is used to visualize and assess the pulmonary artery tree. And then a lung perfusion scan, and perfusion is intentional introduction of drugs and or fluids into the bloodstream, such as during open heart surgery. So a lung perfusion scan, that reveals the patches of occlusion within the pulmonary artery. Pulmonary arteriogram, that is the definitive test for diagnosing pulmonary embolism. The arteriogram will clearly show the lack of blood flow to the periphery of the thoracic cavity from branches of the pulmonary artery. Okay, so you can read all about that. Pulmonary thromboendarterectomy. Okay, trying to make sure I don't need to talk about anything else here. I guess not. But yeah, these are PEs, pulmonary embolisms, emboli. Okay, next on 1018, the decortication of the lung. If blood or pus from a chest injury is not properly drained from the pleural cavity, it coagulates and forms a fibrin layer over the visceral and parietal pleura that interferes with the proper expansion of the lung. The condition is called empyema, and empyema by definition is the collection of pus in the pleural space due to a bacterial infection that is removed by surgical incision and drainage. The main goal of decortication is to restore the normal lung function. Two other goals include controlling infections, such as in the case of empyema, and prevention of deformity. All right, moving on to 1020, there's the upper lobectomy. Under pathology, if a neoplasm is confined to a particular lobe of the lung and hilar nodes are not involved, a lobe of the lung can be removed without disturbing other portions of the lung. Okay, so we are removing the upper lobe of the lung, lobectomy removal. Okay, so on 1022, we're talking about the surgical procedure. On number 7 in the procedural consideration, body temperature irrigation will be needed to fill the thorax to check for leaks. So after we've removed that lobe, we've sealed it off, we've stapled it, we've closed that wound. Now we're going to check for leaks. The anesthesia provider will perform the Valsalva maneuver, which is forcible exhalation or induced cough. So again, I would write next to that, check for air leakage from bronchial closure. So the Valsalva maneuver is a check for air leakage from bronchial closure. It's kind of redundant, but I want to make sure that you understand what this maneuver is. Okay, it's forcible exhalation or induced cough to check for air leakage from bronchial closure. Okay, so that takes us to the pneumonectomy. Okay, so the chief indication for pneumonectomy is bronchogenic carcinoma. And by the way, pneumonectomy is just a removal of the lung. Okay, so make sure that you know the definition of a pneumonectomy. You are removing a complete lung. Less common indications include multiple lung abscesses, bronchiectasis, and extensive unilateral tuberculosis. So on 1023, the surgical procedure, number 4 at the bottom of that, you're going to use doubly clamped. So when you're doing, it's talking about the pulmonary ligament, when you're ligating, you're going to doubly clamp, cut, and tie, which is referred to throughout this chapter and throughout this specialty as CCCT. So double clamp, so CC, cut, C, and then tie, T. Okay, so you're going to need 2 hemostats to go on either side of where they're going to tie off. So clamp, clamp, cut, and then tie on both sides of that those hemostats. CCCT. All right. What I want you to also know on this procedure, this pneumonectomy, on page 1024, that wound classification on the bottom right, this is a class 1. This is a clean wound classification surgery. Okay, most of these are, but I want you to really know that on this one. All right, and the last one on this slide for thoracic procedures on 1025 is the double lung transplant. A lung transplant is performed for a variety of reasons, including emphysema, COPD, idiopathic pulmonary fibrosis, cystic fibrosis, and primary pulmonary hypertension. The procedure is not performed for patients who have a history of cancer or currently have cancer, who have a history of chronic liver and kidney disease, who currently have an infection such as HIV or hepatitis, who had tobacco use in the last 6 months, or who have a history of alcohol and drug abuse. So there is a very narrow population that can benefit from this procedure. And there's a lot of therapy that goes along with as far as psychological therapy. Okay, under the preoperative preparation, all the way on the right-hand side, make sure that you know that you may have to go on bypass, the cardiopulmonary bypass, CPB, that may become necessary. Under practical considerations, all the way on the right-hand side, that second bullet, the donor will be a cadaver or individual who has been declared brain dead. So we're not getting, you cannot offer up, you cannot advertise your lungs to be donated. These will be from cadavers. Okay. And typically you're not going to get an 80-year-old lung. These are people who were relatively healthy, that have healthy tissue, that have donated them upon their death, or that have been declared brain dead. Okay. On page 1026, under the surgical procedure, number 3, look at the procedural consideration. So the surgical team must be ready for the surgeon to indicate that CPB must be used. Okay, so hypoxia, and hypoxia is an inadequate amount of oxygen supplied to the tissues of the body. Hypoxia and or chronic low pH combined with hemodynamic instability are two intraoperative complications that demand the use of CPB. So these are the reasons why you would go on bypass immediately for a double lung transplant. All right, number 6 at the bottom. Tissue that surrounds the bronchus is called peribronchial tissue. That's why I want you to make sure that you understand that peribronchial tissue is tissue that surrounds the bronchus. Make sure you know that. Okay, and that wraps up the thoracic portion of this lecture. So this is the part 1 that you will need to know for the next class. Okay, so on 1029, we're going to start the adult cardiac surgery portion, part 2. This is where the meat and potatoes of CV surgery is, so this is going to be kind of lengthy, probably about as lengthy, if not lengthier, than the thoracic area, but we'll see. We might just be chugging along here. All right, so under the introduction, that second paragraph, cardiac surgery is typically performed in the largest room of the OR suite to accommodate a larger number of OR personnel and equipment, which can be large, such as the cardiopulmonary bypass pump machine, or CPB. So, I mean, you're going to have your perfusionist there, you're going to have your whole team there. I mean, there's going to be a lot of people. So if you notice, your heart rooms are typically a little bigger. All right, the anatomy and physiology of the heart. Dun dun dun. You're gonna have to know a lot of this. So I mean, if you notice, they have a whole area dedicated to this, and it's not just in the form of a table under a procedure. All right, so on 1030. The role of the heart within the cardiovascular system is essential for the circulation of blood, which carries waste substances away from cells to excretory organs for elimination, and vital nutrients and oxygen from the respiration and digestive organs to cells throughout the body. Okay, so let's talk about the location of the heart. And you're going to do a lot of writing. So the third bullet, it is located within the mediastinum with 2/3 of the organ on the left side. Okay. All right. So we're going to be writing some things. So on the left-hand side at the top of this structure, okay, this 22-15, I want you to circle brachiocephalic artery. And you notice where it is. It's also called the innominate artery, INNOMINATE artery. The innominate artery. You also need to write everything I'm about to say next to the innominate artery. It is the first branch from the aortic arch. It carries blood away from the heart. And innominate artery, it means that it's not named or classified. Okay, so there's a lot of information on just one little structure. So the brachiocephalic artery is called the innominate artery because it means it's not named or classified, but it is the first branch of the aortic arch, and it carries blood away from the heart. Okay? All right. Under the coverings of the heart, the pericardium, and the pericardium is a thin serous sac that surrounds the heart. It consists of the serous pericardium and fibrous pericardium. So that protects the heart and prevents it from rubbing against the thoracic cavity wall. And it consists of 2 parts. You need to know the fibrous pericardium and the serous pericardium. Okay. All right, the heart wall on 1031. The wall of the heart is composed of three layers. The epicardium, which is the outer layer of the heart, provides protection and is composed of the visceral pericardium. The myocardium, which is the muscle of the heart that is composed of cardiac muscle cells that contract and force blood from the heart's chambers. Okay, and the endocardium, which is the inner lining of the heart wall, it lines all of the heart's chambers and valves. The endocardium is composed of endothelial tissue, which consists of a single layer of flattened cells. All right, the heart chambers. The heart has four chambers. There's two atria, which those are the upper chambers of the heart that receive blood from the superior vena cava and inferior vena cava veins and the coronary sinus. And then the two ventricles, and the ventricles are the lower chambers of the heart that receive blood from the atria. Okay, so the atria are the upper chambers and the ventricles are the lower chambers. So the atria, which is sing atrium, it receives blood from the veins of the body and is divided by the interarterial septum. Okay, ventricles pump blood into the arteries leading away from the heart. The right ventricle pumps blood to the lungs, and the left ventricle pumps blood into arteries that transport blood to all other regions of the body. And they are divided by the interventricular septum. Okay, so the atria is divided by the intraatrial, the ventricle is divided by the interventricle. Okay, the heart valves. The atrioventricular valve, or AV valve, that's located between each atrium and ventricle. So there's the tricuspid valve, and it's named for its three leaf-like cusps. So tri meaning three. Okay. Then there's the pulmonary semilunar valve, and that's formed by three half-moon shaped cusps, hence the name semilunar. Mitral valve is also called bicuspid because it has two cusps. So bi meaning two, tri meaning three, but the mitral valve is also called bicuspid. And then there at the bottom of that little area, a pathological condition that can occur is mitral valve regurgitation, and that's when the valve does not close, allowing blood to backflow into the atrium. So that's an actual emergency. An aortic semilunar valve that's located at the base of the aorta. The chordae tendineae, or tendinae, these fibrous cords are attached to the cusps of valves on the ventricle side. And the chordae tendineae prevent the cusps of the valve from folding back into the atrium, which would cause incomplete closure of the valve and lead to regurgitation of the blood back into the atrium. Okay, blood flow through the heart. On 1032, I would circle blood flow through the heart. All right, and you're going to need to know this part for your next chapter on chapter 23, the peripheral vascular. This is where this comes into play. Okay. The right atrium receives deoxygenated blood from the superior vena cava, which drains the upper portion of the body, the inferior vena cava, which drains to the lower portion of the body, and the coronary sinus, which drains blood from the wall of the heart. The tricuspid valve opens, allowing blood to flow into the right ventricle, then the valve closes. The pulmonary semilunar valve opens and blood enters the pulmonary artery and travels to the lungs for oxygenation. Blood travels from the branches of the pulmonary artery to eventually enter the capillaries that surround the alveoli. And the alveoli is the terminal end of the bronchioles. They're grape-like clusters within the lung where the exchange of carbon dioxide and oxygen takes place. Okay. All right, so again, oxygen and carbon dioxide are exchanged between the blood and the capillaries and in the air and the air in the alveoli. The oxygenated blood returns to the heart through four pulmonary veins and enters the left atrium. And this slide really gives a good breakdown of what we just read. Okay, so I would kind of memorize this slide. Okay, blood supply for the heart. Two coronary arteries originate from the ascending aorta. Okay, so under the left coronary artery, it says circumflex artery. That supplies blood to the left ventricle and left atrium. And then the deoxygenated blood is returned to the right atrium through coronary veins into the coronary sinus. Okay, cardiac conduction. The cardiac conduction system coordinates the events of the cardiac cycle, and the cardiac cycle is everything that occurs within the heart during a single heartbeat. So first you have your sinoatrial node, which is the SA node. It's referred to as the pacemaker of the heart. Okay, and then you have your AV node, and that's located in the interarterial septum. And then you have your bundle of His, which is the AV bundle, your Purkinje fibers, and then you have your parasympathetic division, which is responsible for slowing the heart rate. Okay, hopefully you were able to find all of those bullets I just read. They're on this slide as well. And then at the bottom, adult normal resting heart rate averages 72 beats per minute. The parasympathetic division is in control through the secretion of acetylcholine, which decreases SA and AV nodule activity. All right, diagnostic procedures and tests. So you have electrocardiography, echocardiography, and cardiac catheterization are useful diagnostic procedures for the evaluation of cardiac disease and may be performed in interventional radiology. Okay, we're going to talk about this in just a second, one of those. On 1033, about halfway down that first column, you have your stress test electrocardiography. That's another diagnostic test. And then further down it says cardiac catheterization studies that include ventricular, arterial, and pulmonary pressures and cardiac output with ejection fraction recordings. So I need you to write something here. Your cardiac catheterization, it provides extensive details regarding valvular disorders. Okay, cardiac catheterization provides extensive details regarding valvular VAL-VU-LAR disorders. Okay, under instrumentation, so there's the routine instrumentation. Under the instrumentation, coronary bypass procedures, which is also known as CPB. So I underline coronary bypass procedures, and then on the third line, CPB. And then on the next line, inferior mammary artery, or IMA. Okay, so I want you to make sure that you know these terms. So CPB is coronary bypass procedures. IMA is inferior mammary artery. Okay, so under the equipment in the second column, you have your CPB machine, your cell saver, defibrillator unit, and your ice slush machine. Okay. Under the supplies, halfway down, make sure you know that you need those cannulation sutures of the surgeon's choice. Okay, so whenever you're putting in your cannulas to shunt the blood out of the body to the CPB machine, you have to suture those in place or else they're going to slide right out because it's so slick in there from all the blood. So you have to suture them in place, and the sutures are listed in that first little bullet. You don't have to know those, but make sure that you know that you do need cannulation sutures. Okay, drugs. So, heparinized saline, that is a blood thinner, and you need to write that next to that. So that a heparinized saline, heparin it thins your blood, so it's a blood thinner. That is used for the intra-arterial irrigation and for soaking the saphenous vein before anastomosis. Topical papaverin for the prevention of vasospasm, especially involving the internal mammary artery. And then on 1034 at the bottom, internal defibrillator paddles and cords. So you always have your defib paddles ready to go. They're sterile. They're usually in a pouch in your drape. Cardioplegia needle and administration set. We'll talk more about this here in a moment. And then on 1035, halfway down, your closed seal drainage unit, the Plurivac. Okay, so on page 1035, under the techniques of cardiopulmonary bypass, again, I'm just reiterating that CPB is cardiopulmonary bypass. And you can see there's that perfusion set in the upper right-hand corner. So you can see how big it is. And so that's why we have to have a fairly large room to do bypasses or any heart case in there, because you have this machine, you have a back table or two typically, two Mayo stands or like a Mayfield depending on where you're at. So there's a lot of equipment in your cardiopulmonary room. Okay, but you can see on figure 2218, there's your cardiopulmonary bypass. There's the heart and all the cords and things that go along to circulate the blood through the body while we have the heart stopped. It's not beating anymore. Okay, so on the bottom of 1035, bottom right, the placement of cannula or cannulae into the right atrium or vena cava for draining venous blood to the pump oxygenator, and the ascending aorta for the return of arterial blood from the pump oxygenator is referred to as cannulation. And so that's the surgical insertion of a cannula into a body cavity or a lumen such as a blood vessel. Okay, so before cannulation, heparin, 300 units per kilogram, must be administered to prevent clotting. So we're going to give heparinized saline into the body, and then at the end of the procedure, we're going to have to reverse that because now we have super thin blood. We need to thicken it a little bit, and we're going to talk more about that here in a moment. Okay, all right, upper right hand column. Because left ventricular pressures are elevated in a motionless heart, causing lung damage or ventricular distension, a vent is placed into the left ventricle. In addition to lowering left ventricle pressure, venting also removes air from the heart. Okay, so lungs and heart are now stopped. Okay. Okay, so on page 1037, you can see the left ventricular venting. And also on 1036, you can see all the cannulas that are going in and how they have to be sutured in place because, again, they'll just slip right out. So in the second column on 1037, myocardial protection during CPB is accomplished with systemic hypothermia, topical myocardial hypothermia, and the administration of cold potassium cardioplegia solution into the coronary arteries via the aortic root and/or the coronary sinus via the right atrium. Hypothermia reduces the oxygen demands of the myocardium, and so is the technique utilized most often for cardiac procedures. Okay? All right, third paragraph. After cardioplegia infusion, ice slush or ice cold saline, which is 4 degrees Celsius, is placed around the heart. A myocardial insulating pad may also be placed behind the heart. After hypothermic techniques have been employed, the systemic temperature of the patient often falls to 32 degrees Celsius. So we are purposefully cooling the heart because things that are cold do not work fast. They work slow, and so we're trying to naturally have the heart stop beating by icing it. Okay. All right, last sentence. A moderate temperature of approximately 28 degrees Celsius reduces oxygen demand on the myocardium by half. And that takes us to page 1038, the coronary artery bypass with grafting, also known as CABG, also known as CABG. Okay, so coronary atherosclerotic heart disease is the most common type of coronary artery disease and is recognized as the leading cause of death in the industrialized Western world. Okay, risk factors for coronary atherosclerosis include, now atherosclerosis is an arterial disorder characterized by that yellowish plaque that lines the inner layer of the arteries, causing a narrowing of the lumen, resulting in a decreased flow of blood to organs supplied by the arteries. Okay, so this is plaque buildup. Okay, so some risk factors. Age. Older people are far more likely to be affected. Gender, the disease affects more males than females. Race, there's a higher mortality rate among non-whites. Genetics, hypertension, cigarette smoking, diet, obesity, clotting factors, and psychosocial influences. Okay. So the term atherosclerosis describes a condition that involves the formation of an atheroma in the intima of medium and large arteries. Okay, so the atheroma, that's that fat, those fat deposits, and the intima, that's that internal lining of the lumen. All right, on 1039, that first complete paragraph, progressive chronic myocardial ischemia. Now, ischemia, that's a lack of oxygenated blood supply to an area or organ of the body. So the underlying pathogenic mechanism of coronary atherosclerosis develops as a result of the progression of narrowing of the lumen of the coronary artery due to atheroma formation. Ischemia is responsible for the clinical manifestations of coronary atherosclerosis. Angina pectoris, which occurs when myocardial oxygen demands exceeds supply and is characterized by substernal or retrosternal crushing pain that often radiates to the throat, back, or left arm. Acute myocardial infarction. Now, infarction, that is an area of dead tissue caused by an inadequate supply of oxygenated blood. So that results in the death of heart muscle tissue and sudden cardiac death. So next to this paragraph, you need to write that this is the main underlying cause of atherosclerosis. The chronic myocardial ischemia is the main underlying cause of atherosclerosis. Okay. Sudden occlusion of the vessel results in acute myocardial infarction, also known as MI, and treatment must be immediate. Okay. All right, on 1040 up at the top, coronary artery lesions usually occur near the origin and bifurcation of the main coronary vessels, but diffuse involvement throughout the branches is seen in advanced cases. Most lesions occur in the left anterior descending artery, or LAD. Now, next to this right here, you need to write that LAD, that's also called the widowmaker. LAD equals widowmaker. Because this has a high mortality rate. If they have any issues, any lesions or blockage in the LAD, there's a high potential, there's a high fatality. The LAD accounts for 50% of all atherosclerotic lesions of the coronary system. The right coronary artery accounts for 30 to 40% of the circumflex branch of the left coronary system and accounts for 15 to 20% of the lesions. Okay. All right, further down, sudden death from MI occurs usually as a result of ventricular fibrillation. Now, fibrillation is abnormal, involuntary, and uneven contractions of a heart chamber. So it's described according to the chamber that is affected, such as ventricular fibrillation or atrial fibrillation. Okay. So, MI can result from ventricular fibrillation, heart block, and asystole, which is cardiac arrest. No heartbeats. Okay. So complications of MI include myocardial rupture, which may occur as a result of a softening of the necrotic ventricular myocardium and an increased ventricular pressure. As blood escapes from the ventricle into the pericardial sac, the heart is compressed, interrupting normal rhythm. This potentially lethal condition is known as cardiac tamponade. Now, tamponade, that is a pathological compression of an anatomical part, okay, and is usually treated by pericardiocentesis. Cardiac aneurysm, or a ballooning of the ventricular wall, can be a result of increased ventricular pressure and scar tissue in the ventricular wall formed by massive MIs, and then heart failure and cardiogenic shock. Okay, so under the preoperative preparation, that third bullet, there are some sub-bullets, and I told you we're going to talk about this a little bit. That second sub-bullet, a Swan-Ganz pulmonary artery catheter that indirectly measures left arterial and left ventricular pressures by assessing right atrial, right ventricular, and pulmonary artery wedge wedge pressures. The Swan-Ganz may also be used to monitor central venous pressures, and we usually shorten that by saying CVP. CVP is central venous pressures. Okay, so you'll hear anesthesia say, let's float the Swan-Ganz, or let's float the swans. That's what they're talking about, this way to measure pressures during CPB. All right, on the right-hand side, the skin prep, you're going to prep from the lower mandible to toes of both legs, bilaterally as far as possible for the chest and abdomen, and circumferentially for both legs. So you're pretty much prepping the entire body except the head, because you're going to harvest veins from the legs, and if you harvest from one leg and if that vein gets dropped or there's something wrong with it and there's holes or lesions or weakening, then they have to go into the other leg to do a harvest. And then sometimes they have to go into the chest to get some veins, and so you just have to prep the entire body. So that's why your patient will be truly naked the entire time. Okay. All right. Under the practical considerations, that first bullet, you don't need to know that, but that is for your information. If you are wanting to be on a heart team, you need to read this, okay? But you do need to know the second and third bullet. The surgical technologist must have excellent anticipatory skills and should thoroughly understand cardiovascular anatomy and physiology, as well as cardiac procedural sequence. The surgical technologist should be thinking 5 steps ahead of the surgeon throughout the procedure and should pay attention at all times. There is not a lot of talking, and if you notice when you go into the heart room, it's very quiet. We are anticipating, we're watching, we're listening, we're monitoring. Everything the surgeon is doing, we need to be 5 steps ahead of him or her. Okay? Last column. You're going to pass off the defibrillation cables at the same time as electrosurgical cords. The surgeon will not want to wait for the defib paddles if they are suddenly needed, so they are prepped and ready to go. You're going to wet the surgeon's hands with saline when tying polypropylene sutures to prevent breaking them. So you'll notice in the heart room they're always squirting the surgeon's hands when he's tying those non-absorbable sutures. You're going to remind the circulator to turn on the suction to the closed seal drainage unit as soon as the chest tubes are connected to it. So that prevents clots from forming in the chest tubes. Do not confuse the terms atrial and arterial when passing cannulation stitches. One is for the right atrium and the other is for the aorta. Okay. Typically, 3 Mayo stands are utilized for CPB procedures. I know at Mercy they use 2. Or a Mayfield. That's whenever I went through the program and through the heart room, I used a Mayfield, which is like 4 Mayo stands put together. And in usual fashion, the surgical technologist should not break scrub and keep the back table and Mayo stands sterile until the patient has safely left the OR. Now I'm going to stop this recording right here. I will have another recording on this slide, but I have to go to class, so we will pick up when I return. Okay, picking up from where we left off, the audio is going to sound different because I forgot my headset, and so I am doing this through the camera. So I do apologize if there is some hollow sounds, and I am also at home doing this. My child is sick today. So anyways, continuing with the bypass procedure. So on page 1042, the surgical procedure, number 1, it says an incision is made extending from the sternal notch. You need to know that that is a median sternotomy incision. So median sternotomy, S-T-E-R-N-O-T-O-M-Y, median sternotomy incision. Okay, and then number 2, it's talking about how the sternum is opened and a self-retaining sternal retractor. That's the Finocchietto, the F-I-N-N-O-C-H-I-E-T-O. That self-retaining sternal retractor is called the Finocchietto retractor. Okay, number 4, under the procedural consideration, that second sentence, it says that there's a papaverin-soaked 4x4 gauze. I need you to underline papaverin. Okay, and then in number 6, it says the vein is flushed with heparinized saline. You need to underline heparinized saline and the heparin/saline solution. Okay, so these are the 2 main drugs that you're going to be encountering in a bypass, papaverin and heparin. Okay. Okay, there's a third one also, but these are the first two. All right, on 1043, in that figure 2222, in B, how it's talking about the internal thoracic or the mammary artery. Make sure that you know that's what that is right there. I would underline that. And then it says the graft options for a CABG is A, the saphenous vein dissection. And so I also underlined A up at the top, the greater saphenous vein. And then B, the internal mammary artery dissection. So the two graft options for a CABG is the greater saphenous vein and the internal thoracic artery, or IMA, the internal mammary artery, IMA. Okay. Make sure you know number 9, the internal mammary artery or saphenous vein is anastomosed to the affected coronary artery with 6/0 or 7/0 gauge polypropylene sutures. It is a very specific detail about a CABG that you need to know. Okay, you are going to be using very small gauge polypropylene, so like a proline, a 6/0 or 7/0 proline suture. Okay, when you're anastomosing these grafts, 6/0 or 7/0 proline. All right, so on the next page you can see the aortic punch. We have some of these in the lab. I can bring these to demonstrate with. But I do need you to know on 1045 number 13, CPB is continued. Chest tubes are placed for the evacuation of fluid and air, and the sternum is closed with heavy gauge stainless steel wire. And so right here, that median sternotomy is closed. Okay. And I have that written. Median sternotomy is closed in number 13 with a heavy gauge stainless steel wire. It's usually a number 5, or is it number 2? I think it's a number 2. Number 2 stainless steel sternal wires. Okay. All right, under the post-op considerations, under the prognosis, the second sentence, recovery depends on the condition of the myocardium, especially the left ventricle, and the degree of atherosclerosis. Time spent on CPB is also a factor. And then further down it says, if the patient experiences none to minimal complications, he or she will be hospitalized for 15 to 21 days. Recovery time is 6 to 8 months. So this is a big surgery with a big recovery time. All right. Now you can see on the following pages what exactly is going on during a CABG. Okay, the median sternotomy on 1046, the sternal saw, that Finocchietto being used on 1047, harvesting the leg vein at the bottom, that greater saphenous vein, cannulation, all that jazz. Okay. All right, so on 1049, under the Pearl of Wisdom, this is FYI. This is for your information, but it's talking about emergency bypasses, but you need to make sure you know that last line, that anything else can wait, including counts. When you're going and doing an emergency cardiac bypass, everything that can be put on hold, just like a C-section, including counting. You get in there and you get what needs to be done to save this person's life. All right, second paragraph. The most significant difference between a conventional CABG and the minimally invasive surgery, or MIS, is that mid-cab and op-cab do not require the use of the CPB machine. Therefore, surgery is performed on a beating heart. This is called a beating heart surgery. Okay. These two that we're about to talk about, that's also on the slide, the mid-cab and op-cab are the beating heart surgeries. Okay. All right, on 1050, on the right-hand side, that last little paragraph there's in red, 2 drugs that are used to slow the heartbeat are adenosine, a metabolite used in treating arrhythmias. Now, an arrhythmia is an absence of cardiac rhythm, A meaning absence, and esmolol, which is the beta receptor antagonist. So then it talks about the mid-cab and the op, or the mid-cabbage and the op-cab. And really, they're both the same, except with just little minor, differences. But number 6 on 1051 under op-cab, the rest of the procedure is performed similar to a cabbage, including closure, with the exception that a stent, now if you remember, a stent is a device inserted to support luminous structures while still allowing passage of fluid, okay, or an external device applied to to secure a skin graft or dressing in place, but in this we're going to be using the stent as to support the luminous structures. So a stent is used because the heart is still beating. Okay, so that takes us to the intra-aortic balloon pump on 1052 with the IAPB. So up at the top, for patients who need cardiac support because they are waiting for cardiac transplantation or cannot be weaned from CPB, mechanical devices designed to assist in circulatory functions may be utilized. The mechanical device designed for circulatory support after cardiac procedures is called an IABP. Next bullet. To be completely effective, the IABP must lower left ventricular pressure during systole, and the systole represents the contraction phase of the cardiac cycle. So that's when the balloon is deflated, and increase coronary artery circulation during diastole. Now, diastole is the period between contractions of the atria and ventricles, and the blood is entering the relaxed chambers, indicated by the lower number of the blood pressure reading. Okay, so that's when the balloon is inflated. All right, so under the preoperative preparation, that last bullet all the way on the right, so you're going to be draping the leg and upper part of leg, including the groin region, okay, because we're going to be going right in that femoral notch, that femoral crease where the thigh attaches to the trunk of the body. That's where you're going to be going in at, so you need to drape off that whole area. Under the surgical procedure number 1, I just need you to know that you're going into the femoral artery. So I have that underlined. The femoral artery is where you're going to be doing all of the work at. It's going to travel. And if you can see on 1053, letter A, it's traveling from that femoral area all the way up into the aorta. Okay. All right. So that will take us to page 1054, the ventricular assisted device, the VAD insertion. Okay. Now, again, if you've watched Grey's Anatomy, there is the LVAD, the infamous LVAD. So the LVAD is the left ventricular assist, so we're talking about the VAD. These are very important. So under pathology, insertion of a VAD is performed for 2 reasons. 1 is to serve as a temporary device that maintains circulation in patients who need a heart transplant. 2, temporarily support an open heart patient who cannot yet be removed from the CPB. A VAD is used to support the circulation from the left, right, or both ventricles. For patients who require a heart transplant, a left ventricular assist device, or LVAD, is placed. The device decreases the workload of the heart by diverting the blood from the ventricle to a pump that pushes the blood into the systemic circulation. Okay, so that's why Izzy Stevens cut that LVAD wire and she's pumping that heart. So that's why. Okay, Denny was going in for a heart transplant. Okay, all right. Okay, so on 1056, the orthotopic heart plant under the pathology. Cardiomyopathy is a general term designating primary disease of the myocardium, often of obscure and unknown etiology. In response to injury, the heart often enlarges, restricting its normal function. Cardiomyopathy can appear in many forms, including alcoholic, congestive, hypertrophic, infiltrative, and restrictive cardiomyopathies. You're going to have to excuse me, I have a sore throat. Alcoholic cardiomyopathy may occur in the individual who consumes large amounts of ethanol over a long period. Next bullet, congestive cardiomyopathy is characterized by cardiac enlargement, especially of the left ventricle, myocardial dysfunction, and congestive heart failure. Hypertrophic cardiomyopathy is characterized by an extensive thickening of the left ventricular myocardium and septum. Next bullet, infiltrative cardiomyopathy results in the deposition of abnormal substances in the myocardium, as may occur in amyloidosis. Next bullet, cardiomyopathies are incurable. Currently, the best treatment is heart transplantation. Okay, you can read all about that there. Let's go on to 1059, the ventricular aneurysm repair. So an aneurysm is a sac formed by localized dilatation of the walls of an artery due to structural weakening. The strength of an arterial wall is in the elastic tissue of the tunica media. Destruction of this layer by any disease diminishes the strength of the vessel wall. Arterial aneurysms may be classified according to cause, shape, location, or structure. There are two types of aneurysm: true aneurysm, in which the wall of the sac consists of one or more of the layers that make up the wall of the blood vessel, and false or pseudoaneurysms, which are pulsatile hematomas that are not contained by the vessel layers but are confined by a fibrous capsule. Atherosclerotic aneurysms are classified as true aneurysms, and you can see at the bottom the various forms of aneurysms. So there's, you can see your normal aorta, the saccular aneurysm, the fusiform, and then the dissecting. And the dissecting aneurysm, those are big time emergencies, because it's exactly doing what the name says. It is slowly dissecting the aortic arch, or wherever the aorta is, apart. And so you're going to start having leaking very quickly. A dissecting aneurysm is, again, something that you usually just don't do counts on until you can get that occluded and clamped off. Okay. All right, so that takes us to 1062, the aortic valve replacement. Under pathology, disease of the semilunar or AV valves of the heart can lead to stenosis of the valves, a condition that can obstruct the normal flow of blood from one region of the heart to another, or to valvular insufficiency, which can cause a reflux of blood into the area from which the blood was ejected during systole. This reverse flow, usually involving the mitral and tricuspid valves, is known as regurgitation. As the valvular disease progresses, the myocardium enlarges to compensate for insufficient flow, and unless treated surgically, with prosthetic valve replacements, congestive heart failure is bound to ensue. And then that last bullet in this column, aortic valve stenosis is less common than mitral valve disease and usually affects males. Next bullet, aortic stenosis impedes the flow from the left ventricle into the aorta, resulting in hypertrophy of the left ventricle as the ventricle struggles to overcome the increased resistance of its outflow tract. The next bullet, aortic regurgitation, like aortic stenosis, is frequently caused by rheumatic fever, which damages the leaflets of the valve and results in an incomplete closure. And here's where we talk about Marfan syndrome. It's another etiologic factor. This disease, which affects connective tissue systemically, results in necrosis and aneurysm formation of the ascending aorta. All right, under pre-op tests, the true extent of aortic stenosis, or cor pulmonale, which is the overload of the right ventricle due to pulmonary hypertension, can be attained with cardiac catheterization. Here that comes back again. All right, last sentence of this area. Cardiac catheterization reveals the extent of the valvular insufficiency, the degree of ventricular overload, the stroke volume, and the ejection fraction. All right, on 1064, under practical considerations, aortic valves are the most frequently replaced valves in cardiac surgery. There are basically two types of valves used for replacement. There's biologic, which is tissue, and mechanical.
Further down, the tissue valves may be harvested from a pig or a human cadaver and may also be constructed from the pericardium of a cow. Further down, porcine or pig and human donor valves usually wear out after a period of 10 to 15 years and so are not suitable for implantation in younger patients because they're just going to have to go back and get a new one when they get older. Mechanical valves are constructed from modern ceramics and are usually implanted into patients under the age of 65 because of their longer lifespan. Next bullet, a valve that combines bovine pericardium with polyester and plastic, such as the Carpentier-Edwards bioprosthesis valve, lasts approximately 14 years and is another option for patients over the age of 65. When Rachel Ray is here on Wednesday, please ask her about Carpentier. She will tell you all about him and her experience with meeting a surgeon that worked under him. And then the third to last bullet, there should never be water on the back table. It would be too easy to accidentally use water instead of saline when filling the cannulas. Water will cause lysing of RBCs, red blood cells. Okay. All right, and then the last bullet on page 1065, still at the top, the SurgTech should not break scrub and should maintain the sterility of the Mayo stand and back table until the patient has safely left the OR. Actually, it's just good technique to wait until they're in ICU and before breaking down everything. Okay, under surgical procedure, number 1. A median sternotomy is performed and CPB is initiated. So we're going back in just like a bypass. Okay, under the procedural consideration, bone wax is used to seal off bleeders from the sternal walls. So just like a bypass, we're going to be using bone wax on the sternum after we use the saw. And that is it for the aortic valve replacement that I need you to know. Okay, so let's talk about the mitral valve replacement on 1067. So the third paragraph, auscultation helps to confirm the stenosis. An opening snap may be heard, which is the result of a forceful opening of the valve followed by a diastolic rumbling or murmur. And I need you to write something next to this. So you're going to be listening to chest sounds with a stethoscope for the diagnosis. So to hear that auscultation, you're going to be using a stethoscope. Okay, so the auscultation is going to be listening to chest sounds with a stethoscope for diagnosis, and you can abbreviate diagnosis by putting DX. Next paragraph, mitral stenosis and atrial fibrillation may cause systemic embolization from blood clots formed within the left atrium that are launched into circulation from the left ventricle. Next paragraph, procedures for surgical repair include closed mitral commiserotomy, which is CMC, open mitral valvotomy for mitral stenosis, mitral annuloplasty or valvuloplasty for mitral regurgitation. Okay, so on page 1069, I need you to know just a few things before we get to the third part. So that first complete paragraph in the second column, halfway down right in red, it says mitral regurgitation can also be caused by mitral valve prolapse, MVP. Prolapse, again, is to fall or slip out of normal anatomical position. So this form of mitral insufficiency is a condition in which some portion of the mitral valve is pushed back too far during ventricle contraction, usually due to redundant tissue on one or both leaflets or papillary muscle dysfunction. And so the next paragraph, mitral valve replacement is performed when damage is too extensive for repair. Now this wraps up part 2, the adult portion of cardiothoracic surgery. This is the only area that we'll be lecturing on or doing activities on on this lecture day. So remember, parts 1 and 3, that's one part of the lecture series, and then this part 2, is the third part.
Okay, so for part 3, this is pediatric cardiac procedures. It starts on 1069, but we're going to really start on 1070. Pediatric cardiac procedures are typically not done here in Fort Smith. They are usually sent to Children's, either in Little Rock or North, in Fayetteville, or usually to Tulsa. Okay, these can go south in a hurry, so we don't really have the equipment or the people here to deal with these kind of procedures. So the first procedure on 1070 is the repair of atrial septal defect, or ASD. An ASD is an abnormal opening in the wall between the two atria. There are three types of ASD. There's the ostium secundum, sinus venosus, and the ostium primum. The ostium secundum type is the mid-atrial septum and is the most common. So the second bullet in the second column, the ASD results in a shunting of oxygenated blood from the left atrium across the defect into the right atrium. And then second from the last bullet, the child who is asymptomatic for the defect should undergo surgical repair around the age of 4 to 5. Okay. All right. So this was a congenital abnormality that can be corrected. All right, on 1072, closure of patent ductus arteriosus, which is PDA. So PDA is a failure, and I put a box around failure. PDA is a failure of the fetal structure to completely close after birth. In fetal life, the ductus arteriosus connects the pulmonary artery to the aorta in order to shunt oxygenated blood directly into the systemic circulation by bypassing the lungs. And so I drew a line from that fourth line where it says aorta in order to shunt back to completely close at birth. So this is the failure of the aorta to be completely closed off to the rest of the heart. There is a hole in the aorta. We have to go close it. Okay, they are having blood leaking in. Actually, blood leaking out. Okay, there's yes, yeah, there's this abnormal hole, if you can see on 1074 and B, see there's this little bridge, usually, and like I described in the orthopedic lecture when we're talking, when I talk about how your knee, how that compartment is built while you're in utero, the same with the heart. So you have these two structures, the pulmonary artery and and the aorta, they're together, but as the fetus grows, they separate. And so if this little branch, this patent ductus arteriosus is still there, then there is blood coming into structures that then it shouldn't. So we have to go close that hole. Okay, I hope that makes sense. But you can see in D, they're both unattached now. You clamp. So if you can see, if you look in the letter C, clamp, and they're going to cut and then tie, which you can see in D. Now you're suturing. Okay, on 1075, the repair of coarctation of the aorta. Coarctation of the aorta is a localized narrowing of the aorta in an otherwise normal vessel. So this is a very tiny aorta area, and we need to go and dilate it because the blood flow is not adequate. On 1076, that bullet up at the top, at the bottom of that first column, collapse of the cardiovascular system ensues rapidly with hypotension, tachycardia, and tachycardia is a fast heart rate that is greater than 100 beats per minute, and tachypnea, which is fast breathing, as the initial symptoms followed within hours of anuria and metabolic acidosis. So you're working on an infant. You're working on a newborn when you're doing this. Okay, you can see what's going on 1077, that coarctation, that narrowing, if not, sometimes it's even closed off, but it's just so small that they will not get adequate blood supply or oxygen to their organs, and so this is a newborn being having surgery. Okay, all right. On 1078, the repair of tetralogy of Fallot, which is TOF. TOF is the most common cyanotic heart defect in children. The classic form, of which there are several variations, includes the following 4 defects. So there's VSD, infundibular or pulmonary valve stenosis, an aorta that overrides the VSD, or right ventricular hypertrophy. The first 3 defects are congenital, and the 4th is acquired as a result of the increased pressure within the right ventricle. Okay. Now I want you to know that you may not be tested on the tetralogy of Fallot in this chapter, but when chapter 23 comes around in the next lecture, or in 2 lectures in this unit, you will have a quiz. This will be on your chapter 23 quiz. All right, at the bottom of the second column, TOF results in cyanosis, which may appear soon after birth, in infancy, or later in childhood. These blue babies may have sudden episodes of severe cyanosis with rapid breathing and may even lose consciousness. Okay, so they are blue because they are not getting enough oxygen. Okay. So under the preoperative diagnostic tests, as previously described for open heart procedure. So this is an open heart procedure for children. Okay, under the equipment, it's the same as for open heart surgery with the addition of the following items. Okay, so I just want you to know, you don't need the following items, but just make sure that this is the same surgery, same equipment, but you're also adding a perfusionist. And you need to write that under equipment, perfusionist. So same equipment for open heart surgery and a perfusionist. P-E-R-F-U-S-I-O-N-I-S-T, perfusionist. And that wraps up this chapter. Let's see. This talks more about, like, the next couple slides talks about the preoperative preparation and the procedures that we just talked about. But we'll go over this more in class.